So hi, we'll be discussing case number 29 from the new Odell. And so it's about protection and whatever precautions you need to take about or things to be considered when you're making a dental x-ray. It's just a review about how cautious you should be and how you should try and avoid taking unnecessary x-rays. To be honest and to be precise, nothing exactly comes in the exam from this case, but this is a good stepping stone to build your base when you're planning for your radiology preparation. So when you're preparing for radiology, we'll be using 1000 MCQs and 1400 and previous SPQs to learn a little bit about radiation physics. I'll be teaching you in the life classes radiation physics also. I'll be teaching you about various radiographic errors. That is the most important thing that ADC concerns itself with. So I will be taking life classes about radiographic errors. I'll be giving you so many resources to read about them. And then also you would be reading a little bit about radiation protection. So this chapter covers a little bit about protection, a little bit about what is required, what is not required, about the various views and their exposures. And it also initiates you, I would say, on starting to look at radiograph and identifying the errors. So what ADC asks is a lot more based on the errors. I will be covering all of them in the live classes, but this is an initiating point that how to start looking for errors on the radiograph. The chapter talks about digital radiography and its related errors, but in the exam, you're usually given your intraoral and your conventional radiographic intraoral techniques using your regular films. And the errors would be related to OPG, intraoral techniques like your bite wing, IOPS. So we'll be training and preparing ourselves for all of those. So you can consider this chapter as a stepping stone or somewhere where to start with radiation, right? Consider this as that. I mean, it would not be like an accurate term, or I would say it doesn't get asked in the exam as directly, but yes, it does initiate you how to expect radiology questions. So we'll begin this case. Let me share my screen. It's a short, sweet case. Teaches you and gives you a hint about there's an importance of radiology in this exam. That is why I'm covering this, because radiology is a very important topic and it sometimes becomes a very definite and a defining moment in the exam for passing paper 4. And radiology is not just confined to paper 4 anymore. It does get asked in paper 1, 2, and 3 as well. So you are going to learn a lot about radiology. I have added Langlay's questions in a weekly plan, and there's errors that you would be doing. So Langlay's, the errors, and using your 1000 MCQs, 1400 past papers, and the Mega Master file will create a solid base on radiology. So starting somewhere, this is your X-ray cautions. A 25-year-old female patient who's attending your practice for the first time is worried about having radiographs taken. How should her concerns be addressed? After a full clinical oral examination, you decide that taking radiographs is justified, and the radiographs that you are going to take for this patient is given in this table. You're going to go with both sides bite wings, IOPAs on the lower left first molar, and an OPG. So the reason why you're taking bite wing is because you want to assess existing and restorations and periodontal status. This tooth is tended to percussion on the lower left first molar side, and it also requires extraction or may require RCT. That is why an IOP is being considered. And who assess a partially erupted lower third molar, as there is a history of recurrent pericoronitis, and OPG is being taken. So also when we start taking the live classes and when I go on and teach you the radiology files, we will be talking about which radiograph is preferred for this particular condition. Which radiograph would you go for, say, about identification of periodontitis, or for a survey, full mouth survey, or for your third molar. And we have also read in other Odell cases that for a particular condition, which radiograph is the best. And that is one of a very characteristic question in any SBQ of ADC, because no matter whether that question is related to any endodontic problem, any periodontal problem, or it could be any tumor, any cyst in paper 3. So any of those conditions would require first a radiographic examination. And based on that, based on the history, there will definitely be a question, which is your go-to radiographic view. So as the course goes on, please understand that you would be developing a knowledge base, and you would be developing an acumen to immediately identify the best radiographic views, which would be required for any particular condition, lesion, any dental pathology, or any other jaw-related condition, right? So that's what we are aiming at. Now, the patient is concerned about radiation. Current regulations require you to have a meaningful discussion with the patient regarding the risks and benefits of radiographic investigation. So you start to provide those and risk information. What 3 general guiding principles must you follow in deciding whether or not to take any radiographic examination? We've been answering a particular question in the 1000 MCQs. For example, I give you that there's this question that what is wrong about pregnancy or radiology in pregnancy, and there's this one option that X-rays are not contraindicated. So that is a very true statement. X-rays are not contraindicated in pregnancy, but the truer statement, or to add to that statement, would be, but it should always be indicated by the patient's condition, and it should be justified that you do require the radiographic view to come to a positive outcome, to come to the diagnosis and plan the treatment. So they are not contraindicated absolutely, but you should not be taking X-rays just like that. It should be justified. Justification is necessary. Then comes your optimization and then limitation. So each exposure must have a net positive benefit. It should be aiding in diagnosis, treatment planning. Then it should be as low as reasonably practical. So you should be taking the minimum views, the minimum dosing to get the best view. And then the dose to individuals must not exceed the recommended limits. And these are the guidelines. So justification, optimization, and limitation. Even if it's given by the UK guidelines, even Australian guidelines are following the same protocol. The basic guidelines for radiation protection throughout the world stands the same. It should be a justified radiograph, and it should be optimized by keeping the dose low for each particular exposure, and limitation. So the cumulative dose to that particular individual must not exceed the recommended limit, right? What is the patient dose associated with exposure of these radiographs? So you're giving bite wings, first molar, and an OPG. You're taking 2 bite wings and 1 IOPA and 1 OPG, right? So radiation dose measuring is complex. This is also, in fact, one of the questions in ADC where they ask you that dose of combined 2 bite wings and IOPAs is less or equivalent to your OPG. So radiation dose measuring is complex. Effective dose, which is absorbed dose corrected to compensate for the type of radiation and susceptibility of different tissues, is usually quoted. So the effective dose, right, for an intraoral radiograph, which is either a peripipe or bite wing, is somewhere around this 0.003 to 0.022 millisieverts. And for the OPG, it would be your 0.0027 to 0.075 MSV. So somewhere if you see the maximum doses of both, the OPG is almost 3 times that of 1 intraoral. Is that correct? 0.022 and 0.075. If you look at the highest limits of intraoral and OPG, you can derive that OPG is somewhat 3 times the dose of 1 intraoral. So that is why when you get a question that 2 bite wings and 1 IOPS or 2 bite wings, 1 IOPS would have, OPG would have slightly lower or equivalent dose to that combined intraoral views. Anyone who's been doing the course with me before has read that question. You have been through this question, so you know what I'm talking about. You know which question I'm talking about. And this is our reference for that question and for that reference. Okay. So now you have a solid reference that yes, OPG dose, a single OPG dose would be less or equivalent to the combined dose of bite wings and IOPS. Perfect, right? So now, because these technical terms do not mean much to most people, how can you reassure your patient? The patient can be reassured that the doses are very small and equivalent to a tiny fraction of a natural background radiation. to which we are exposed throughout the day. If the patient wants to know actual figures, then they should be told that the annual dose from background radiation varies around the world. So you don't really have to worry about the doses. ADC is not asking you the values, right? So going further, the patient accepts, but points at the hazard warning sticker on your X-ray cubicle. What exactly are the risks? So this is very easy and it is understandable, which you can easily also try to break down and understand, is that at these low absorbed doses of dental radiology, there is only one significant risk, that is of cancer induction. The one high significant risk that comes from dental radiology or any other radiology because of the medical purpose is the cancer. This is a very low frequency and it's completely random or stochastic effect. What are stochastic effects? Stochastic effects are dose-related probability. Like when there is increased dose, the probability of getting the cancer would be higher, but the severity is not dose-related, right? So stochastic effect is that radiation can affect the DNA or the genetic constitution of a person. Once the DNA gets affected, it can actually trigger a cancerous gene and can lead to cancer, right? That is a stochastic effect, but its effect is dose-related with probability, right? If you are giving increased doses, then the probability, the chances of getting the cancer would be higher. But even at low doses or high doses, severity is not related to the amount of dose. Probability or chances of getting the cancer is related to the dose. It gets higher with increased dose, but the severity is not dose related. So even at a lower dose, if you got the cancer, then it can be too severe as well. And even at a higher dose, you can get very mild changes or no severe disease at all, right? So the stochastic effect is that the dose is affecting the probability of the cancer, but doesn't affect the severity. Now, the risk of developing a fatal malignancy as a result of taking a periapical radiograph varies depending on the equipment used and dose delivered, but in best practices, it is estimated to be 1 in 10 millions. And from OPG, the risk goes to 1 in 1 million, right? So from the intraoral techniques, it goes to 1:10 million, and from your OPG, it goes to 1 in 1 million, right? Now, the patient wants to know about how you would ensure that you receive the minimum dose of radiation necessary, what methods are used to optimize the dose to patients, and how do they work? Now, that's an important question, and if you remember, we have had the questions like this: which of these would increase the patient's dose, which of these would decrease the patient's dose or exposure? There have been various topics and options that we have been dealing with, like your filtration, your pole emission using your fast films, KVP, exposure times, distance from the patient's mouth to the focal spot. So there are various different factors that we have been reading as options, and we have to find out the correct or the incorrect one, right? So this table actually gives you all the factors which affect the amount of dose received by the patient. So first is clinical justice or the justification of whether that X-ray is required or not. The patient should only be X-rayed if the investigations are clinically necessary. Published evidence-based or selection criteria should be used during the justification process. It would prevent the unnecessary X-ray dose, and that's why it is completely advised. Then the equipment. It should be best set from 60 to 70 kV because this gives you the optimal energy X-ray for the dental radiography, the best balance between the tissue penetration and the image contrast. So it gives you the safest tissue penetration. If you keep it below this, it would not be penetrating the tissues, the energy would not be that higher, and plus it would not be giving you sufficient density, so you would be requiring higher exposure times. And you don't go even higher also, because if you keep even higher, then tissue penetration would be achieved, but the image contrast can be too dense, right? So 60 to 70 is considered the optimal energy, which gives you the safest amount of dose to the patient. Then aluminum filtration, I will be explaining when we begin the classes, I will be explaining all the X-ray tube parts and components and where the filtration is kept. So aluminum filter is actually kept at the exit point of X-ray from the X-ray tube. So when primary beam is formed, X-ray beam is formed, it goes out of the X-ray tube and there's an aluminum filter which is kept. So that absorbs the lower energy beam. So it actually gives out a far more uniform and a higher energy beam, so that the patient doesn't get this unnecessary low energy beam, which would not be penetrating and would be absorbed by the patient's tissue. So filtration again is the best way of reducing the patient's exposure. It would absorb the low energy X-rays that would otherwise be absorbed by the skin. These would increase patient's dose and would not contribute to the image. If you remember, if you've taken previous classes, you know this concept. I have taught you this concept also before, where we learned about the questions how to reduce the patient's exposure. So I'm sure with this concept, a lot of concepts are coming back to you, they're getting revised, which is also great. Now, X-ray sets for intraoral radiography should have a rectangular collimated beam. It will reduce the width of the beam to the minimum required. It will channelize the beam to only a specific area, and it makes more difficult to aim the beam accurately. And so an image receptor holder should also be used with your collimated beam. Then X-ray should be checked for safety on installation and regularly thereafter. You should perform quality assessments, just like you will also perform your quality assessments for sterilizers. Even your X-ray machinery should be checked for the quality. It should be like checking the KV, determining the dose, there should be no leak, etc. Right? Then image receptors should be used for the fast film, like F-speed film or higher, or digital sensors, like your PSP sensors, which are the fastest. Faster detectors would reduce your exposure time, thus would reducing the dose which is received by the patient. Then extraoral radiographs should be taken by using intensifying screens, which is part of your cassette. When you use your OPG, the cassettes contain the intensifying screen that actually helps you use a less amount of X-ray, and those intensifying screens transmit, they receive X-ray, and then they multiply and amplifies, increases the amount of radiation that reaches the film. So in turn, it reduces the amount of X-ray that might be received by the patient, right? So intensifying screens are used because that also helps in reducing the patient's exposure. Then the radiographic technique should be the most accurate as possible, like your paralleling technique, and it should be used with denaming devices, etc. Minimum number of images should be taken. If your images are distorted, they're not accurate, you might be taking unnecessary over repeated exposures. So retakes can be avoided when you use your aiming devices, because it would be a reproducible image, reproducible view, and with maximum accuracy. Even processing errors should be avoided so that you're not unnecessarily taking a retake. And this will reduce the number of inadequate images caused by malpositioning of the beam or image receptor, or even your processing errors. So these are really important factors by which you can totally and significantly reduce the amount of radiation received by your patient. So now you are planning to go ahead and take a radiograph of this patient by using a PSP, which is your digital imaging system, and using the photoreceptor, digital receptor. The benefit to the patient depends on the diagnostic information or yield provided, that this in turn is dependent on the quality of the radiographic images. Now the quality assurance has to be done. There's criteria, but of course, because it's not ADC relevant, so we are not reading this, how to perform the quality assurance for the digital radiography. Digital radiography is not as much, but we'll use these errors because they are also common with your intraoral film placement. So when you have your film placement, even film can have similar errors. That's why I'll be covering these errors, and that's why it makes this chapter a little bit of important. So going ahead, now we're talking about, there are certain films that are given to you, you have to identify what is wrong with these images. So this is the first one, it's an IOPA, and you can see that this was supposed to be the film where pictures should have been obtained, and only this much has been obtained. That means your collimator was actually located in a wrong manner, and that's why it gave you a cone cut. It was a rectangular collimator, that's why you got a rectangular cone cut. If this was a circular collimator beam, then you would have got a rounded cone cut. So cone cut is a white radio opacity that you see which cuts off. That means the film was not even exposed at this side. And that's why upon processing, no radiation reached here and it came out white. One thing you please must remember, what areas appear white and what areas appear black on the film, which do not get any X-ray, right? Which do not receive any X-rays, they would be white. That's why enamel, because enamel completely absorbs and completely absorbs all the radiation. That's why no radiation would be passing through, or very minimal radiation would be passing through enamel and not reaching the film. That's why enamel comes really opaque. That's why hard tissue comes opaque. Pulp is soft tissue. It has no potential to absorb much of the beam, and much of the beam passes through it and reaches the film. That's why those areas come black. And that's why this was completely air in the patient's mouth. That's totally black, no absorption. Pulp was slightly granulomatous, some tissue, some gel-like tissue. So definitely some got absorbed, but still it led to radiolucency. Right? So that's your criteria of getting the black and the white areas. So this image is coned off. It's called cone cut. The part of the image receptor has not been exposed. This happens when the spacer cone is not aligned correctly to the image receptor. In this case, the main reason for cone off is incorrect orientation of the rectangular collimator within the open-ended spacer cone. Note also that even if the rectangular collimator has been aligned properly, it is unlikely the apices of the teeth still would be visualized. So they have also taken the wrong size of the receptor. Going to the next view, what is wrong with this one? So if you look at this, you can see the periapical area. There is no foreshortening, there's no elongation, everything looks okay. But one error is that you see these scratch marks. Now this scratch marks can also be on film. If your film was damaged with your nail or emulsion got peeled off before processing, when you were taking out the film, that can also lead to these scratch marks. Even on the digital sensor, if there can be scratch marks, and that can appear like this. So this is again a periapical radiograph of the lower left, right first molar side. Image shows several white lines or marks. These are artifactual due to the scratching of the phosphor layer. And then they have taken another view, simply expose the sensor with the radiograph with the beam. There was no tooth that they were trying to take a picture of to even highlight those scratch marks even more, right? So these scratch marks, when they simply expose the film or the sensor with the beam, not taking a radiographic image, so this scratch marks became even more highlighted. So that's highlighting it here. Now there's this another picture, 29.4. You see that there is overlapping or double image formation, right? So that is when you see a shadow of the actual picture, that means it is blurred image. Blurred image is because of the movement. It could be the movement of the receptor, or it could be the movement of the patient. Anything can lead to the blurry image here, and this is the blurred image caused by the movement of the patient or of the image receptor during the exposure. Now coming to picture number 29.5, it's the left side bite-wing radiograph. And first thing, an ideal radiograph should open up the contacts, right? So there you see overlapping on all the proximal contacts. That is totally not what is desired out of the bite-wing. It should open up the proximal contacts. Here it's overlapping. Now this can be because of two reasons. Either the film or the sensor was not placed correctly, parallel to the tooth, or the beam horizontal angulation was altered. So either there's something wrong with the receptor or with the beam. So if there is horizontal angulation problem with the beam placement or the sensor or the film placement, the proximal contacts would appear overlapped and it would be an absolutely wrong image. This is a left bite-wing radiograph. Image is distorted. There is severe overlap of the contact points, making KD's assessment impossible. Although an image receptor holder and beam aiming device have been used, the image receptor has not been placed parallel to the arch. Here there was a problem with placing the film or receptor. Consequently, the X-ray beam will not pass through the contact areas, leading to the overlap. Now what is wrong with this one? This is usually seen with only with your digital sensors. A radio opaque dot would be seen. Now that is when you reverse your receptor and expose it from the backside. Similar concept can be learned for an IOPF film. If you were using a film, then you know that in your film packet, you have the film which is backed up by metallic lining. So you have metallic foil lining, right, which absorbs the excessive radiation so that there is no scattered radiation in the patient's mouth. So metal backing also helps in reducing the patient's exposure because it absorbs whatever extra radiation has been also leaving the film and would go to the other side of the mouth, right? So if you place the film also reverse side and expose the backside of the film, then you would see the track marks on the radiograph. You would see the track marks on the radiograph, which would be the pattern of your metallic backing. Right? When you do Langley's, you would see these artifactual pictures. You will see these images that would be resembling your tire marks or your kind of a herringbone pattern. Those would be your indentations on the metallic backing. So that would be like a light shadow over your dental image. So that would indicate that the film has been exposed from the wrong side. Does that make sense? Anyone who was preparing with the last batch must have done all the radiographic errors. Do you remember seeing this and remember having discussed these herringbone pattern or the tire mark pattern indicating your wrong side of the film exposed? And because when you put the wrong side of the film exposed, this metal would be facing the radiographic beam first. So metal will absorb a lot of radiograph or your X-ray beam, and then less amount of radiation would be reaching the film. So the image would be also lighter. So the image would be lighter. That would be your wrong positioning of film. But you can have same artifact, and if your density is normal, then that is your processing error, which indicates the indentation of an automatic processor. Indentation of a nylon mesh over which the films pass from one compartment to the other. That can sometimes also make its imprint on the film, which would be similar track. But if the density appears normal and you have the same track, then it's your automatic processor error. If the density appears lighter and you have the same herringbone pattern or your indentations or tie marks, then it's your wrong side of film exposed. Does that make sense for everyone? Am I highlighting both the problems which would appear same, but there's very slight difference? And I think we'll be discussing that in one of the Odell cases also. So that has been discussed in one of the Odell cases. So one is automatic processor artifact and one is your wrong side exposed. So light radiograph is wrong side exposed, normal density, and the same tie marks is your automatic processor indentation. So this radio opaque dot here, that is when the wrong side of the digital receptor has been exposed by the radiation. This particular brand of PSP has a round metal magnet on the back, so that's why you get a round dot. Sometimes you may get any geometrical other square or rectangular dot as well. It is the magnet in this sensor that has caused the radio opaque shadow. Although this image is still of diagnostic value, it must be flipped in the horizontal plane because it has given you the mirror side of the image. It is actually the right side incisor, but on the radiograph it looks like you've taken the left view. So because you flipped the sensor, it gave the mirror image of the right side, so it looks left, but actually it is your right side view which was taken. So these were the errors. So overall, what are the advantages of digital radiography over your film-based system? The use of digital radiography has a number of advantages. One of the most important is that image receptors are more sensitive. They allow lower patient doses. And in addition, the image production is quicker. It allows your immediate assessment of image quality. The processing errors risk goes down. Image can be enhanced digitally to extract useful information from underexposed or overexposed images and may be optimized to assess specific dental conditions such as caries or periodontal bone levels. Finally, also you get an electronic storage of data, which means that you can even access them quickly, share them, and that's the benefits of your digital radiography over your film-based radiography. So less exposure, quicker assessment. You can modify the image to your usage and also can save it and can access it quickly whenever required. So those are your benefits, and those were few of the errors. And I tried my best to create a parallel with the film-based radiography. I hope that made sense to everyone. So with the wrong side exposed, we draw a parallel with the film side, and then with your bite wing also, the sensors on the film also, you get the bite wing errors. Similarly, the horizontal angulation was incorrect. Then the scratch marks, if the emulsion gets peeled while processing before you're trying to take out the film, before you put it into the processor, if the emulsion gets peeled off, then you get the scratch marks. And this is your blur image, which will be similar when you have the film placed also, and it moves or the patient moves. Cone cut is also saved with your film-based radiography. So all of these errors that we slightly started on. So you can call this chapter like an embarking chapter on radiology. This is how it prepares that where we have to go, what all we need to learn. So we talk a little bit of the radiation protection here. We talked about the KVP importance, we talked about the filtration, we talked about the fast films, the digital sensors, and then we talked about your justification, optimization, the ALARA rule. All these are really relevant information. So we can say that whatever we will be reading in depth in radiology has been briefly given you a glimpse, right? So that you get a heads up that where I'm heading to when I'm preparing for radiology. So when I have your weekly plan ready, you know that you have to read from Langley's, which will prepare identifying your lesions, identifying errors, and knowing the normal versus the abnormal radiographs. And also it will tell you how to identify various diseases and conditions on radiograph. So diagnosis also you will learn, the processing errors. So there's a lot that you will learn from Langley's. And it is just a beginning, or it's just a minor glimpse of where we are heading towards in radiology. I hope this was useful. I hope it brought to highlight, and also we got some really great references for a few of the questions in the exam, which are already there. So I think it's a great learning experience. It's a great chapter with few very good informative points. So I hope that was useful and you would gain from it. Keep revising it also. And thank you so much, guys.